everyone, my name is Gizem. Today, me and my friend Ege will present you our study. Our topic is evaluation of factors affecting the health-related quality of life of patients with chronic renal failure receiving hemodialysis treatment in Northern Cyprus. This is our outline. First, I'll start with the introduction, then my colleague will continue with the methods and results, and finally, I will present the discussion and conclusion. As you can tell, we have a quite long research name, and there are some terms that you might be unfamiliar with, so let's start by defining them. What is health-related quality of life? CDC defines health-related quality of life as patients' perceived mental and physical health and how a chronic disease interferes with day-to-day life. Chronic kidney disease. It's a type of kidney disease which is characterized by gradual loss of kidney function. It has 5 stages, and the last stage is also known as the end-stage renal disease, in which the patients have an established kidney failure. When a patient is diagnosed with ESRD, there are 3 treatment options. The patient can get a kidney transplant, or the patient can either start peritoneal or hemodialysis, and these treatment modalities are interchangeable. In hemodialysis, the patient is bound to a machine which is responsible for filtering the blood, and usually 3 sessions a week, each session lasting around 4 hours. When we take a look at the previous studies, in this study which was conducted in India, they found that the quality of life of renal transplant patients were worse compared to the hemodialysis patients. And being a female and lower levels of education were associated with worse scores. In another study which was conducted in Egypt, they showed that quality of life of hemodialysis patients was very poor in all domains, and employment was found to be the only significant predictor. So, our research question is, what are the factors affecting the health-related quality of life of ESRD patients receiving hemodialysis treatments? Our aim is to obtain the result scores of these patients by using a disease-specific quality of life tool to define the factors affecting the health-related quality of life and to assess the correlation between demographic characteristics, medical factors, and quality of life in these patients. Based on the literature review, we expect to find that advanced age and female gender will have a negative effect on symptoms of kidney disease subscale. Being a male and having social support from relatives will lead to a positive effect on physical component summary scores. Higher education levels and employment will overall lead to higher scores, whereas having other comorbidities will lead to lower scores. The importance. National Kidney Foundation states that physical core scores and mental core scores are important predictors of mortality and morbidity in ESRD patients. An increase in either of these scores will lead to a decreased risk of mortality and hospitalization. Also, Center for Medicare Services emphasizes the necessity of routine annual measurement of health-related quality of life at all dialysis units. And this will give physicians an opportunity to identify the patients who are at increased risk and who may benefit from interventions.
Okay, this is the quick review of our timeline to get oriented. It all started in the last year when we chose our topic and the methodology, and then in the 5 months we carried out our plan, and now you're watching us. And our study is a cross-sectional study that took place in the 3 state hospitals which had the hemodialysis units in the 3 main cities of the North Cyprus. And our research is approved by the Eastern Military University Research and Publication Ethics Board and the Ministry of Health. After the ethical approval, we went to these 3 hospitals in the Famagusta, Nicosia, and the Kyrenia, and we obtained the patient list. However, these were the wrong number of the patients, so we had to exclude some of them. And according to our exclusion criteria, we took all the patients who accepted to take part in our research, except the ones that are below the age of 18, taking hemodialysis less than 3 months, having cognitive impairment, dementia, and psychosis, and acute kidney injury patients, and the peritoneal dialysis patients. Our population size were, of course, 185, but then after our exclusion criteria, we ended up with 162 patients, and which was a quite good chance for us because the whole population was reachable. So we wanted to use this chance, and we didn't sample our population, we just take all of them to make our research fully representative of all the patients taking hemodialysis in the hospitals of state hospitals. Our independent variables are the social demographics like the gender, the marital status, and the age, and the lab parameters. And our dependent variables are the scores of the health-related quality of life domain. From every patient, we took the demographic information like the age, gender, and marital status. And lab parameters are taken from the archives. They had the biochemistry and the hemogram lab tests. And we also use the kidney disease specific questionnaire, the KDKL36, which I want to talk more about it. It has two parts. The one part is about the general, mental, and the physical health of the patients, consisting the first 12 questions. And the other part is specific to kidney disease. It's about the symptoms, problems, its effects on the daily life, and its burden on patients. And the special thing here is that the scores are obtained by the perception of the person about their own health. For example, for the kidney specific part, the scores were from the 0 to 100, and 0 for the worst, and the 100 was for the perfect perception of their own health. However, on the general part, there was a population-based norm, which was at 50 and plus minus 10 standard deviation, and below the 40, the results, the scores were actually considered as bad. There was no need for permission to use the tools from the RAND, the provider of our questionnaire. They said that as long as you just give the correct citations, you can use our tools. And our study was in English, but we wanted the Turkish version of it, so we used the translated version. The Mrs. Öğütmen from the Marmara University, they translated our questionnaire, and they found that the results demonstrate the high reliability and the validity of this questionnaire for the Turkish patients on dialysis. We use Excel and the PowerPoint, and also we use the IBM SPSS for our analysis. And when we did the Shapirovic test, and we found that our data is not normally distributed, so we carried out the non-parametric tests, the Spearman correlations, the Kruskal values, and the Moomen test. At the same time, we did the multiple linear regression by using the stepwise method. And we took the p-value less than 0.05 as the significant. And for results, before going to the inferential statistics, I want to make you familiar with our population. About 85% of the people wanted to participate in our research, and the mean age was 66.5, and the 65% of them were the males. Most of them only went to the primary school, and most of them were retired. When we asked the question, who takes care of you when you are in need, they answered as their spouse. But when you look in general, the 93% of them have someone to take care of them when they are in need. And most of the patients have at least one extra health condition in addition to their kidney problems. And most common of them were the hypertension and the diabetes mellitus. And when we look to the all scores, they were low scores according to population, and especially the burden of kidney disease, physical component summary, and the mental component summary were low. First, we hypothesized that the females have lower scores in the physical component and the symptoms of the kidney disease subscales. We hypothesized this, and then after the test, we saw that actually it was correct. They had significantly lower scores in the physical component summary and the symptoms of the kidney disease scores compared to the males. And in addition to that, they had the lower score in general in the other three domains as well, but it was not significant. We also hypothesized that as education level increases, the effects of the kidney disease subscale score also increases significantly. However, as you can see from this graph, there was no huge difference between the mean values of the patients who only went to the primary school and the postgraduate ones. So actually, we couldn't find any significant association, surprisingly. And when we compared the patients according to their age groups, we saw that the patients above the age of 60 had significantly higher score for the three domains of the health-related quality of life: symptoms, effects, and the burden. And then we further evaluated this by using the Spearman correlations with using the same three domains. We actually saw that there is a direct correlation between these three scores and the age. So which made us reach the conclusion that as age increases, these three scores of the health-related quality of life also increases. And we also did the multiple linear regression by using the demographics and the lab results of the patients. And at the end, we found that there are 4 variables that are significant predictors of the health-related quality of life domains. These are the age, number of comorbidities, and some 2 lab results. The total number of comorbidities, total protein, and the C-reactive protein seem to have a negative impact, and age seems to have a positive impact on the health-related quality of life scores.
In this study, which was conducted in Egypt, they found that women have lower quality of life scores compared to males, which is also supported by our study. However, the reason behind this is not clear, but it seems to be related with the social and psychological factors rather than the kidney disease itself. In another Greek study, they found that the patients with higher levels of education have better quality of life. And a possible explanation is that education allows these patients to have a better understanding of their illness, and they are more likely to adhere to their treatment regimen. And another alternative explanation is that higher levels of education may reflect higher levels of income, and consequently the ability to afford treatment. In this Indian research, they found that the quality of life scores were higher among the working groups compared to the unemployed ones, and retired group bring the least score. However, we found the opposite. In our study, retired patients had the highest scores. We believe this is due to the patients seeing retirement as an opportunity to enjoy life, or maybe they're feeling more free and independent, and they have more free time for their hobbies and families. And in this Greek study, they showed that elder patients had worse quality of life scores. But in their study, they divided the participants into 3 different age groups and found that the ones who are over 60 had the lowest scores. But in our study, the ones who are over 60 had the highest scores. We think this is due to the survival bias, meaning that the patients who are above 60 years of age, they survive many things through their lives, such as losing their loved ones and other diseases, and because of this, they might be overlooking to their kidney disease. And in this Korean study, they showed that the more comorbidities you have, the worse your quality of life is. And our results are also consistent with this. And if you remember from our results section, in our study, the most common comorbidity was hypertension, followed by diabetes mellitus. And in this research, they found the opposite. And in this bar graph, you see the KD-QOL scores of different countries. And when you take a look at the United States, it got high scores in most of the domains, whereas India got the lowest scores. As all of you know, India is a developing country, and the healthcare services are not very sufficient compared to the United States, which is a developed country with more stable economy. And when we take a look at the Northern Cyprus, it ranked the 2nd place in most of the domains, meaning that we have better outcomes compared to the India and European countries. Our study had some limitations. Since most of our population was consisted of elderly patients, we faced with some barriers while communicating with them, such as hearing deficits and cognitive impairments. Also, some patients were really sensitive to the questions related with social support, and in some cases, we even had to stop the interview and exclude the patients. And also, some of the patients were in really bad condition when we tried to approach them, and because of this, they refused to participate. And all of these factors lead to a decrease in our sample size, and as a result of this, we weren't able to reach all of the ESRD patients as we planned in the first place. So overall, our study proved that health-related quality of life of ESRD patients are severely impaired, and also age, C-reactive protein, total number of comorbidities, and total protein were found as the only significant predictors of quality of life. And in the end, we would like to recommend the Ministry of Health measuring the health-related quality of life routinely in all dialysis units. And because of this, the healthcare providers will be aware of the risk factors so they can make some targeted interventions to the patients who are at increased risk. These are our references, and thank you so much for listening.